Hi.
Hi, Michael.
Hi, everybody. So we're going to try to unpack as best we can in the short amount of time we have a couple of really complicated but interrelated issues, homelessness and mental health. So let's begin by talking a little bit about the scale of homelessness in New York. What is the problem at the moment? Because I think it's perceived as a crisis in the city.
Sure. So New York City is a city of about 8.5 million people, and the shelter system right now houses about 80,000 people, right? And that you have to take that population, though, and divide it into pieces. There are about 57,000 people in families in the system. That, by the way, includes about 26,000 children. And there's about 23,000 single adults in the system. And that's in addition to about 3,500 people who are living outside. In parts of Europe, they're called rough sleepers, right? So you'd have to combine those two numbers together to get about 84,000 people total. And the subset of that group that we're going to focus on in the next 15 minutes is the single adult people. So the 23,000 in the shelter system that are single adults, and almost all of the 3,400 people who are rough sleeping are single adults. Because that is the group of people, the single adults, not the families, where the mental health component is a prominent component that we're going to focus on. And I'll say one last thing, and then I'll hand it back to you, Michael, that for family homelessness, mental health is a less prominent and different issue, because family homelessness is more driven by socioeconomic things, poverty, lack of affordable housing, domestic violence, right? And then the single adults, the mental illness part is a part of the pathway into homelessness.
So there were a lot of numbers, and I just want to underscore a couple of things. So you said 80,000 people homeless in New York City. That's a massive number. And I just will say, as somebody who writes about housing a lot, New York also has a couple of million people who are rent subsidized, and about another million people who live in public housing. So there's an enormous population of precariously housed people in New York City, in addition to this number. But we're talking, as you said, about a small subset of the homeless population here that has identified mental illness issues or identifiable mental illness issues, not the family group. Now, this number has been rising, obviously, for a lot of reasons, one of which is what I just said, that the cost of housing in New York City has skyrocketed. Over the last 40 years, it's gone up about 20 times, whereas the relative adjusted for inflation numbers for income has remained the same. So it is clear that it has become increasingly impossible for a vast number of people in the city to remain sheltered. Since that's changed, let me just ask you, what has changed in terms of psychiatric care? Has it kept up with the larger numbers of people and greater demand?
The short answer is no, right? But it's not because there hasn't been more psychiatric services added to the system. It's that the need for those services has outstripped that demand. It's grown faster than the demand. I will mention, though, one piece of the psychiatric care system that there's been an appreciable reduction of capacity over the years, which is the inpatient hospitalization capacity, both acute and longer-term inpatient capacity, has been shrinking sort of steadily for the past 20 years. COVID increased it a little faster for complicated political reasons. And the reason that is important is because some of the people we're talking about, amongst the people who are homeless living with mental illness, include among some of the people with the most severe symptoms for whom hospitalization is often helpful. So the reduction of hospitalization capacity has affected that group.
So let's get back to, by the way, that doesn't mean that there aren't doctors like yourself who have gone out into the streets and done work to sort of, if they're not coming to a hospital, you're going out there. Maybe you could just describe very briefly what that consists of.
Sure. So I'll start by saying, well, why are there people like me to begin with, right? So something like 2/3, 3/4 of, remember, single adult people who are homeless in a place like New York City in the States are living with either serious mental illness or substance use disorders. And that serious mental illness or substance use disorder is one of the contributors to their homelessness to begin with. It makes people vulnerable to homelessness. Although I want to make an aside that the vast majority of people in New York City living with serious mental illness are not homeless. This is a small subset of people. But the mental illness does make people vulnerable to homelessness. Okay, so that's a point I really, really want to make. Now, starting in the mid to late 80s, right, there was this growing recognition that it was this serious mental illness among this group of people that was driving a lot of the homelessness. And on top of that, this is a group of people who, for a variety of reasons, really have trouble accessing care in the sort of brick and mortar mental health system, the traditional mental health system in New York City. So then what you started seeing in the late 80s and early 90s, these programs developing to bring psychiatrists, mental health providers, to where people who are homeless get other services, so like shelters, drop-in centers, and then also you started having these street outreach teams that were bringing psychiatrists to people in Tompkins Square Park, to church benches, to church stoops, to park benches, to the Staten Island ferry terminal. So that's when you started seeing the development of these kinds of programs.
So let me just, you were going back in time. Let's go back a little bit further and just for people here, describe, because you know, I spent more than a year focusing on the roots of homelessness and focusing especially on Houston, a city which has been able to reduce, in Texas, which are able to reduce its homeless count by 2/3, which is quite the opposite of what's happened in New York City. And in doing that, I was looking at some of the roots. New York City has very specific reasons why homelessness has increased, and with it, some of the mental health issues that go along with it. So I'll do the home part. Among other things, back in the 50s and 60s, so a half a century ago, the city began to get rid of what were called single residence occupancy hotels, which were basically sites where people with addiction issues, some people who were mentally ill, people who were, it was basically the Bowery, flop houses, they were often also called, but they were safety nets for hundreds of thousands of people, and the city began to close them at a time when the economy of the city was declining, and closing them was considered part of urban renewal. Actually, it was considered a good thing to close them and encourage the production of more middle class and luxury housing. But one of the obvious results was you immediately had more than 100,000 people who had been housed in some form who were now homeless. And we've been trying to make up for that housing crisis ever since. But there was also a huge shift in psychiatric care that happened at the same time, right?
That's right, yes. So if you go back to the mid-50s in New York State, there were about 90,000 people, give or take, living in state hospitals, these state institutions, throughout the state, right? And a lot of them in New York City. Then in 1952, the antipsychotic effectiveness of chlorpromazine was discovered by accident, actually. But that discovery ushered in this like sort of era of hope that psychiatry would be able to more effectively treat people with schizophrenia. We're speaking about only one of the serious mental illnesses that leads to this, right? So, and that hope was, you know, people took up that hope. For one thing, people, you know, were very aware of, some especially very highly, what's the word, salacious stories.
Publicized well-known crises.
Right, crises.
Scandals, yeah.
Abuses in the state hospital system, right? So there was a group of, you know, there's sort of one group of people who wanted to close state hospitals because of that. And so the promise of being able to treat people as outpatients with the advent of things like chlorpromazine and haloperidol, right? And then also, that was an opportunity for the state government to shift some of the cost of the care for people from the state hospital system, which is paid for by the state, right, to the federal system, right? So the Medicare and Medicaid, those being enacted in 1965 also helped this process along and helped the state shift some of the costs to the feds, because if you discharge someone from a state hospital and they seek care in the community mental health clinic, what are they using to pay for that care? They're using Medicaid, and that's federal, right? So there was this cost shifting that was also encouraging this movement. So fast forward to now, remember I told you there were about 90,000 state hospital beds circa 1955. Now there's 900, right? So the state hospitals were many, many things, but one of the things they were is they were housing, right? And this is the last thing I'll say about this, that now it's not the case that anyone's old enough now to have been discharged from a state hospital, but what you find is that there was a significant portion of especially the single adult people who are homeless. If it were 1955, some portion of those people would be living in state hospitals now.
Yeah, I mean, it's a really interesting story, I think, just in a general sense, because it tells the arc of privatization, corporatization. But it's a story of sort of false hopes as well, both on the housing front and obviously on the front of psychotropic medications and treatment. But that number is a really powerful one, 90,000 down to 900. Just as we're talking about a housing crisis in which we're dismissing hundreds of thousands of people who were housed. But we're talking about these two things, and I just want to make sure it's clear why we're tying them together, because they're not the same thing, and we're talking about a small population of homeless, and yet obviously homelessness itself is a challenge for anybody that can lead to mental health issues and addiction issues and so forth. So talk about that for a minute. Why does the public confuse, at least in New York, but not only in California and other places where you have homeless crisis, there's often a confusion between mental health and homelessness, which is stigmatizing to both. Maybe you could talk a little bit about the numbers again and make this clear. And why does that confusion happen?
Yeah, so what's being conflated, I think, is sort of the population of people who are homeless as a whole and this very small group of really visible people who, I'm going to oversimplify this a little bit, but this very small group of people typically are living with the most severe symptoms that are the most resistant to the care that's being offered people, right? So, and that's who you see when you're like walking down the street, when you're sitting in the subway, right? What you're not seeing is all the people who are living with serious mental illness who are doing fine, right? So I did a little math in my head a couple days ago. So there's 8.5 million New Yorkers, I already said that, right? So my guess is about 170,000 New Yorkers living with schizophrenia. If even every single person who was rough sleeping was living with schizophrenia, which is not the case, right? It's maybe 10 to 15 to 20%. That would mean only 2% of people living with schizophrenia in New York City are homeless, right? So we're talking about a small number of people. And then even amongst people who are homeless, many people who are living with schizophrenia accept the help that's being offered them, right? Remember I told you there's outreach psychiatrists seeing people on park benches, seeing people on stoops, right? Many people accept that care, and that care is very effective and very helpful and helps people engage in the housing process, right? But New York City is doing street outreach now the way it's been doing it since about 2007, right? So I won't get into why it started being a certain way in 2007. Between 2007 and now, this is a little back of the envelope math, we've housed that outreach operation of the whole city, which I'm a part of, has housed enough people to have wiped out the street homeless population 3 times over, I think, maybe 4, right? So it's not that the process isn't working. The process is working really, really well. If it wasn't working, it would be a much, much more worse problem. What's happening is that we house somebody, they get replaced by somebody else, right? It's not the same people who have been around since 2007. It's like new people joining the ranks.
Right, I mean, it's not like there's a finite number of people out there at any point, and if you just house them, the problem always goes away. Right. It's a question of how quickly, efficiently, well you house people. What we do seem to know, and Houston was a good example of this, is that housing people, not a shelter, but actual housing, and especially for those people who need it, permanent supportive housing, which includes services for them, is extremely effective. So people in those housing situations stay in those housing situations. In America, though, there's a lot of controversy now around even that issue. Housing first, which is what the policy is called, although it's proven to work very well, has now become yet another divider between right and left, with the right now arguing that people should sort of deal with their addiction and other problems before they're allowed to get housing. The analogy I came up with when I was reporting on this in Houston was, which is the argument for housing first, is if somebody's drowning, the guy who's going to save him or the woman who's going to save him does not swim out there and say, look, you've got to learn to swim before I'm going to bring you into shore. And then, you bring someone into shore, and then they can more, easily deal with their problem, or not, but at least they are housed. And by the way, at that point, they're not homeless, which means that they join that vast majority of people who may, let's say, be schizophrenic, but are living behind closed doors, and therefore are not included in this population of people who are so visible. Okay, but having said that, housing first is not just the only thing that is now, out there as a question. One of the questions that's come up as well is around, we did all this deinstitutionalization. In places like New York and California, the mayor in New York, the governor in California, have sort of stepped into the territory again of whether or not we should find ways to institutionalize people who are resistant to that, who are unsheltered on the street, and who clearly need help but don't take that. So let's end at that point too, because it's a really, I think it's an issue that many people don't understand, and it's also an issue that is, I assume, a kind of third rail for many people. So in your profession, that question of reconsidering institutionalization in some form for people who may not immediately, take to it. I don't even know how to put it. What's the state of that in your profession and your own feelings about it?
Yeah, so that conversation, it is really a third rail, and it's a conversation that is actually not really being had. People are sort of skirting around it, right? So let me just say it very quickly. It's a small group of people who have been offered help. They've been offered care. They've been offered housing. Like, we know every person who's sleeping outside in New York City. We know all these people. They've been offered things. They're declining those offers. Many of them, it's because it's a symptom of their mental illness, right? One of the symptoms of certain mental illnesses is the denial of the mental illness to begin with. Well, I'm not mentally ill, why would I accept her help? Okay, so that group of people, the conversation we're really, in my opinion, not really having is what are we going to do with that group of people? One of the possible answers is some kind of involuntary something, involuntary treatment, involuntary institutionalization, involuntary housing. That's a hard conversation to have. I don't know what I think about that, right? But that's the third rail conversation.
Well, let me help you with that just a little bit, because there are people who just want to live on the street, and who the overwhelming majority of those people are taking care of themselves. They're quiet. They're not actually trying necessarily to be seen. There's a subset of that who often, a tiny subset of that, who are the ones making headlines, driving the news, and driving the political conversation. And that comes from acts of violence. And I believe the previous panel was also talking about the fact that we in America, at least, have a criminal justice system and a prison system that is our de facto version of reinstitutionalization, which is not equipped to do that.
That's right. And it's, this all comes from the liberty side. It's the liberty versus the state's interest in taking care of people, right? The liberty part of it has trumped the state's interest in the last 30 years or so, right? That's the conversation we need to have. Like, should we swing it back in some way or not? And again, I'm a little agnostic about that. It's a philosophical question too. But until that conversation's had, it's that little group of people. We're not going to find the end of that, right?
I just wanted to end, we're just about out of time, but I did want to say, you know, as we've been discussing this, and we've talked about this before, Ben, you know, I think as a New Yorker, you are too, and for many people out there in places like New York, California, and so forth, the perception of the problem, and when you hear a number like 80,000, is gigantic. And yet, actually, the population of people we're talking about who are really the most problematic, both to themselves and perhaps publicly, is actually quite small. This is a problem we can fix.
Yes, yes, it's a small, well, do the math, right? So 8.5 million New Yorkers, 85,000 homeless, that's 1%. We're already down to a kind of a small number. The number of people we're talking about, these visible people that are really making people take notice, we're talking about hundreds of people, maybe a couple of hundred people, maybe 300 people, not a lot of people. So numbers-wise, it's a manageable group of people. The problem is that we haven't decided what lane to take with it. That's the problem, I think.
I'm encouraged by the idea that it's a solvable problem. We're having trouble fixing our problems these days. Maybe this is one we can fix. Thank you, Ben.
Thank you, Michael.
Thanks.